move on for the sake of time to the next segment, which is ALK-rearranged lung cancer. ALK rearrangements are in roughly 3 to 5% of all non-small cell lung cancer adenocarcinoma. It's a crowded space. We've got a lot of drugs that have made their way. We, of course, have started out with crizotinib from the profile trials showing a benefit over chemotherapy. And we have other drugs, of course, that have now come in, ceritinib, alectinib, brigatinib, lorlatinib. We'll talk about these. Shirish, you want to start out with the alectinib data and also mention the ceritinib data with a SYN4?
Sure. So the alectinib data that was presented at ASCO was an update of the ALEC study that was presented last year's ASCO and was published in the New England Journal of Medicine. This was a global study which included patients that were found to be ALK-positive or had ALK-positive tumor based on a centrally tested IHC test. So that's how the patients were selected, and they were randomized to alectinib at its standard dose of 600 milligrams BID versus crizotinib at its standard dose of 250 milligrams BID. At last year's ASCO, the median follow-up was about 17 to 18 months, and that showed an improvement in progression-free survival with a hazard ratio of 0.47. That translated into a median progression-free survival of about 11 months with crizotinib, but it had not been reached in patients with alectinib. At this year's ASCO, there was a further follow-up of now a median of about 27 months, so about a 10 extra months of follow-up. And the hazard ratio for progression-free survival actually was a little better now with a hazard ratio of 0.43 and almost a 35-month median progression-free survival in the patients treated with alectinib. And so an impressive almost 3-year progression-free survival, a median progression-free survival in alectinib patients with the median progression-free survival in crizotinib patients of about 10.9 months. What was also seen, and again confirmation of the results presented at last year's ASCO, that patients both with and without CNS metastasis at baseline had benefit with alectinib or had improved progression-free survival with alectinib. There were no other sort of safety signals. Overall, the drug patients who received alectinib had somewhat of a better tolerability as compared to crizotinib. And so this basically showed not only confirmed the results that were presented and published at last year's ASCO and then published in New England Journal of Medicine, but basically with a longer follow-up now we have a suggestion that the benefit may be even better than what was perceived from last year's results. We also have another drug that is approved, not necessarily in the, by the way, based on the ALEX results, alectinib now has been approved in the United States, actually in November of last year, for frontline treatment of ALK-positive advanced stage non-small cell lung cancer. So another next generation ALK inhibitor that has been evaluated in the frontline setting is ceritinib. This was in the ASCENT-4 study. This was actually compared with chemotherapy, unlike an ALEX study where it was compared with crizotinib. Patients with ALK-positive disease were randomized to ceritinib at its standard dose of 750 milligrams versus chemotherapy, either pemetrexed with either cisplatin or carboplatin. And the primary endpoint was again progression-free survival. It did show an improvement in progression-free survival with a hazard ratio of about 0.55 that translated into a median progression-free survival of about 16.6 months with ceritinib and about 10 months with crizotinib. What was interesting is when data was analyzed based on whether the patients had brain mets at baseline or not, there was not much difference in the median progression-free survivals between the two arms in patients who had baseline CNS metastases. So it appears that even though ceritinib may provide a better outcome, at least as compared to chemotherapy, that it may not address effectively patients who have a baseline CNS metastases. Not to mention the fact that the drug does have some tolerability issues, particularly when it comes to GI toxicities. Now, there have been subsequent studies that have shown that if the drug is taken at a lower dose of 450 milligrams after a meal, that it may be better tolerated. Nonetheless, at the present time, based on the ALEX results, the preference has been for alectinib, and I don't think ceritinib as yet has officially received approval for frontline treatment.
Yeah, it's unfortunate. I think it's a great drug, ceritinib. It just doesn't have, the toxicity, again, seems to be prohibited in the context of, I think, really good drugs, really effective drugs that don't have that same toxicity profile. Anyone use ceritinib on the panel and have experience with it?
Well, I don't use it frontline.
Yeah, but have used it in any treatment continuum of it? Yeah.
Yeah, so we usually, I have had, either they do well with it or they don't, right? So I have had some patients that I start off at the dose of 750 that have done okay. And then I've had other patients I had to dose de-escalate to 600 and then 450 with food. Yeah. But the whole point is that we are sequencing these ALK inhibitors. Yeah.
And I'm going to make a little philosophic point that this old drug development paradigm of maximum tolerated dose has done a lot of patients a lot of disservice in this era of targeted therapies. So they are tested the same way, and this dose of 750 was totally unnecessary. So long before they did the study in 40 patients with food of 3 pills, because food does promote absorptions of TKI, which was not a recently learned fact. That has been known for more than a decade. There was even an editorial in JCO by Mark Ratain and Ezra Cohn called Real Value Meal, where they showed the exact same study with lapatinib in breast cancer in 3 pills with food, Big Mac fries. That's why they call it Real Value Meal. And then they gave 5 pills to other women on an empty stomach. And GI toxicity is night and day different. So since I started doing that on my own 3+ years ago, I have patients on this drug, ceritinib, without any problems.
So you have a fair amount of experience with it, with a reduced dose.
Yes.
Okay.
And it can be tolerated. I mean, you can create a situation, because, we have to, right? Because in time, everybody begins developing resistance to whatever TKI they're on. And we're going to have to circulate all of them through all of our patients to get them through.
I think a practical aspect is, though, that Alex was comparing a TKI to a TKI, whereas Ascent-4 was comparing a TKI to chemotherapy. And though one suspects that if ceritinib had been compared to crizotinib, maybe the efficacy would have been better. But when you have data that shows one TKI being better, I'm not sure that that people would necessarily switch away from alectinib.